Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, The Aging Spine, presented by Dr. Rajiv Saigal, neurosurgeon with UCSF and Washington Township Medical Foundation. Dr. Saigal is an associate professor and neurosurgeon scientist at the University of California, San Francisco. He is board certified by the American Board of Neurological Surgery. Please welcome Dr. Saigal.
Thank you, and welcome to our audience. We have some in-person attendees, and we also have a virtual audience. So it's a pleasure to be with you today, both for the people in person and our virtual attendees. Today I'll be talking to you about the aging spine. This is going to be tailored towards a general audience. I don't expect that people who are listening are medical practitioners, so we'll try to present this information in a general format where people can understand no matter their background. So what are some of the changes that happen with aging? Here's a nice cartoon that shows the progress of how we move, basically from infancy, when we first start to crawl, to when we start to be more upright. And then, of course, with aging in our senior years, we start to bend forward a little more and start to maybe look like we're stepping back a few steps in this progression. And there's a lot of ways in that how that affects the way we feel, the way we move, and our risk factors for certain spine conditions. So the first part of the aging spine that I want to talk to you about is the change that happens with bone density. So this is a graph that shows that our bone density increases in our early years of life. It peaks around 30 to 40 years old, as you can see on this graph. It's slightly different for males and females. In blue, you see the male graph, and males tend to have slightly higher bone density than females. And then once we pass 40, start entering 50 and beyond, our bone density starts to go down. And that's just a natural history. That's the way human bones age. And the bone density loss tends to be a slightly more significant drop-off in female patients, and that has to do with hormonal changes that are associated with menopause. So in today's talk, I'm going to intersperse some cases that I've seen in my practice and some ways that the aging spine may manifest in a clinic like mine and in a way that sometimes necessitates surgery. So one risk, unfortunately, with losing bone density is that you are at more risk of fractures, and specifically spine fractures. So this is a patient that I saw in my clinic. It was an 85-year-old patient who presented with a worsening lumbar pain or low back pain. And it started one day for him after he did some heavy lifting. And this is an MRI scan that he got, and there was a number of different degenerative changes. When you have something like this happen, when it's severe back pain that's not relenting, you want to see a doctor, and that if you start with your primary doctor, they may refer you to a specialist like me. In a scan like this, one has to tease out, there's a lot of degenerative changes and changes that have to do with aging, but which are the ones that are clinically important? And to assess that, I am going to look at a patient like this and combine what he tells me, what I find when I examine him, and what the scan shows. And with those combination of things, I thought what was bothering him the most was this spot right here. You can see this is an MRI of the spine. The vertebrae should look like this. It should be a whitish box. But you can see the one below it looks darker. It looks like it's lost some height. And this is what we would call a compression fracture that we think happened when he was lifting something heavy. And, you know, maybe he could have lifted that same heavy object 40 years earlier and wouldn't have suffered a compression fracture, but partly because the bone density was low, it put him at risk for this. Now, just because someone has this does not mean that they need surgery. a provider like me would generally assess them and often try some conservative therapies first. But in that case, that did not work for him. So he was a candidate for a minimally invasive procedure where we basically just try to build back the mechanical strength in the bone by injecting some cement. This is a procedure called a kyphoplasty, and what you can see in this bright white spot is the injection of cement at that area that was fractured. And that procedure is actually a minimally invasive one. We just have to make 2 tiny incisions that are each just a few millimeters, and patients actually go home the same day after a surgery like this, and this smaller procedure actually significantly helped with his back pain. Okay, here's another type of fracture that's common in the elderly who have lower bone density. This is a more severe fracture. This was a patient who's 71 and had a ground level fall. He fell forward and hit his forehead, and I'll point out what to look at in this scan. The fracture is right here where I'm pointing with the mouse. This is the second cervical vertebra, C2, and this part right here should be connected over here. So basically he has a fracture and a dislocation at the top of his spine. Basically he broke his neck. And because of that, it was pushing on his spinal cord and he was getting weak in the arms and legs. So thankfully this is also a treatable problem. If you ever suffer a bad fall like this, one would have to come in through the emergency department. And this patient was treated with a fusion of his spine from C1 to C2 and a decompression, and he recovered very well from what was a bad injury. So the question you might be asking is, what can you do to maintain and support your bone health and try to prevent fractures like this? So the simple things that one can do that have to do with the metabolism of bones. So sunlight helps convert vitamin D into a format that our bones can use. So it's important to get sunlight as much as you can. Obviously you want to be protective to your skin, but still get exposure to sunlight. Sometimes that's harder in the winter months, but just simply getting out and walking is useful. And for more severe cases of bone density, you often need to talk to your primary care doctor. And some of the specific treatment options are outside of the scope of this talk, but what I would recommend is if you have any concerns about bone density, particularly as you get to 70 and beyond, you really want to talk to your primary care doctor and say, hey, first, do I need to check my bone density? There are special scans. A common one is called a DEXA scan to see if you have any signs of low bone density. And there's a lot of different medicines that can be used as treatment options for those who do. And even if you have a scan that shows that you have low bone density, there are ways to build it up with medicines like that, as well as simple therapies like over-the-counter vitamin D supplementation and sunlight exposure to help minimize your risk of fractures like in the patients that I just showed you. Okay, what's another common change to the spine with aging? Posture. So here are some common postures and how they change over time. So on the left, you'll see a younger patient, patient in the 30s, who tends to stand upright. And that's the way, of course, we were made to stand. This is a way that we have very good biomechanical support. Our muscles that support our spine don't have to do extra work to keep us upright. But one of the unfortunate parts of normal aging is that we will gradually bend forward. So you start to see that in the mid-40s, more in the 50s, and particularly 60s and beyond. One of the things that we see in particular is called thoracic kyphosis, where we're going to bend forward more, and that's the stereotypical way of seeing someone in their senior years just kind of bending forward. That can be problematic for a few reasons. One is that it can cause pain because your supportive muscles in your neck and back have to do more work to keep you upright. Another is it may force you to look down a bit. That can put you at risk for falls if you can't see your environment when you're walking. This is a recent study that looked at what are the normal mechanical parameters for people as they age. And I'm going to take you through what I think is the most important part of this graph is this bar on the left. So you're seeing patients at different ages of life on the x-axis. Youngest would be on the left, and oldest would be on the right. And these patients are measured on x-rays, like the picture you see on your left. And this would, the example in this particular x-ray is a patient who's very well balanced. They're standing up perfectly normal. They're not bending forward or backwards. Their head is square over their pelvis. So this is how we like people to be aligned. And what happens with normal aging is we'll go from being in normal alignment, like this image, to being pitched forward. And that's what they call C7, S1, SVA, or sagittal vertical axis. And these actually were in asymptomatic patients, patients who did not have symptoms. And the older patients, above 71, seen on the right, were at least 3 centimeters pitched forward on average, and they actually didn't have symptoms. We start to think of it as being more problematic when it's 5 centimeters and beyond. And that's important for a spine surgeon like me to take into account when we see a patient in clinic. Just because someone bends forward a little bit absolutely does not mean that they need surgery. But when it gets past a certain point and becomes debilitating, sometimes they do. So I'm going to give you one example of a patient who had adult spinal deformity. She was in her late 60s and came to me with low back pain, and not just low back pain, but she felt like she couldn't stand up straight. And in addition to the back part, she also had shooting pain down her legs that was radiating into her thighs. And when I examined her, I did notice both standing up and walking. She was walking really with a stoop forward posture. She just couldn't stand perfectly upright. And so to examine a patient like that and fully evaluate them, I'll get these type of x-rays. These are called standing scoliosis x-rays. And it showed that she had curvature both looking from the front, this is called a coronal curve, and looking from the side. This is a sagittal plane deformity. And she was stuck in this bent forward posture because of her deformity. Now, even in a patient like this, we're always going to try conservative measures first, physical therapy, over-the-counter meds, things like that to see if we can get them better. But if we can't and they're still debilitated, there are surgical options for cases like this. And this patient underwent a fairly extensive surgery to realign her spine. And as you might imagine, that's a lot to go through, but we can do these surgeries safely in patients in this age group and beyond. And this patient improved significantly after having her spine realigned with a deformity type surgery. Okay, what's another type of change with aging that's common? Back pain. The news flash, unfortunately, is that all of us will get back pain at some point in our life, and certainly it does trend up with age. So this is a bar graph. Men are shown in green, women are shown in red. And starting at the left, we have the youngest patients, 0 to 4, who basically have no back pain. And then this is just going to gradually go up in terms of prevalence. How likely is this that we're going to get back pain at these different ages? And you can see it's fairly low in the early years of life and then really starts picking up 50s and beyond. And the highest prevalence, as you might guess, are patients 80 and beyond. So we're all going to get back pain in some capacity, but that doesn't mean there aren't good ways to deal with it. It doesn't mean there aren't ways to try to prevent it. So one important point I want to leave you with is that most cases of low back pain do not need surgery. That is the good news. Many times it's musculoskeletal strain, and conservative type therapies will often work for that, even if some time is needed. But there are some preventative measures that one can take to try to ward this off and minimize your risk. And there's a variety of ways to stay healthy in our senior years. And I want to talk about different components of this. And some of the next slides I'll present to you are official recommendations of the North American Spine Society, or NASS. So first of all, ergonomics. We can all benefit from trying to have the best ergonomics we can when we sit, when we work. First of all, a common position, just almost everyone uses a computer in their life or sits at a desk. You want to have your feet on the floor, your knees and hips level. Try to sit up as straight as you can. It's so easy to get into that bent forward posture when you're sitting, and that puts extra strain on your back. So you want to just adjust your desk, your monitor, so your monitor is in the line of sight, and your back muscles have to do as little extra work as possible. And then standing desks are more common now. You can customize your office to try to do that. It's good to take breaks, to stand up, to try to change positions. For those who have access and want to, a standing type desk is thought to be good and less strain on the low back. What about other everyday activities? Driving. Ergonomics is important for driving too. You want to adjust your seat height, have your knees slightly bent, your chair slightly reclined, so you have a straight line of sight. You don't want to have too much bending forward with your neck. It's good to use a lumbar support so your back feels fairly neutral and supported. And if you take long drives, you want to take breaks, take short walks, stretch in a way that you don't strain yourself. What about housework? Ergonomics matters for housework too. Standing upright, keeping your elbows in. The main thing when you're really doing anything that might involve your back is trying to limit the torque that you put on your torso and the bending that you do in the low back. If you do cleaning somewhere low in the house, it's good to use a stool and try to be in a sitting position rather than like totally bent forward in a way that's really going to strain your back. Lifting. We all want to be like the person on the top where we can lift our children and our grandchildren and enjoy that fun part of life. But lifting, whether it's a young child or a box that you're moving around the house, it's really important to let your legs do as much of the work as possible and minimize the strain on your back. I see a lot of patients with injuries from heavy lifting, and sometimes it's also a mental adjustment that you can't lift the same things you could when you might have been a little bit younger. So again, legs do the work. Try to avoid twisting and bending with the back. Know your limits and how they change with time. And also think about if you're moving something, what's going to be in your way to try to avoid falls and having a clear path. Okay, here's another important change with aging. This sarcopenia, which is a medical term basically for muscle loss. And this happens for a variety of reasons. Sometimes it's physical inactivity. We tend to do less as we age. Sometimes it's low vitamin D and calcium. And sometimes there's some medicines that have side effects, like using steroids, which people may need to take for autoimmune or inflammatory conditions. And what the problem with sarcopenia is your muscles will atrophy and get smaller, and it actually also has some relations with osteopenia, and that when you use your muscles less, it also can contribute to bone loss and your bone density getting lower as well. Some of those things can be dietary if you have low protein intake or have too high fat in the diet, and there can be hormonal changes that are related to this. Now, sarcopenia affects us in many ways. In patients I treat who have surgery, I have to worry about this because it does affect surgical outcome. And this is the example of a recent paper that showed that in patients who are having surgery for spine tumors, it actually affected their likelihood of survival. And so they show here, the green cartoon would be an example of someone with still really strong muscles, good muscle bulk, and the blue would be someone who has sarcopenia, where the muscles have kind of atrophied and died down. And then on the right, you see the overall survival curve, and it was highest in the patients who were able to maintain their muscle mass, and lowest, as you might guess, in the ones who had low muscle bulk. So what are some of the things that you can do to try to maintain that muscle bulk? The simplest and easiest thing to do is walk. We really encourage our patients to walk, both patients I've never operated on and post-operative patients. We like that as the kind of the simplest, safest exercise. If you do go for walks, we recommend trying to have an upright posture, again, to support the back. Try to do brisk walks for cardiovascular health if that's safe for you. It's a good idea to walk with your partner, a partner, as you get older, especially if you're at risk of falls. The last thing we want a patient to do is fall down and have a new injury if they have any issues with balance. And just tracking your progress in a journal or notebook can be helpful. Some people like to use the step calculators. You don't have to do that unless you want to, but some way to track your progress and motivate yourself to walk frequently. What about other type of exercises? We really like aquatic therapy, particularly for seniors. The pool water tends to support the spine. It has its buoyancy. It often is easier to tolerate for people who already have some degree of back pain. And so you can look in your community for places that offer aquatic therapy, and there's often group classes that can be helpful. The general recommendation is to try to exercise at least 3 times per week, and ideally 30 minutes or more. Softer exercises are good in our senior years. Aquatic therapy will be one. Tai Chi and other kind of softer movements just to maintain balance and movement can also be good options. Here are some specific simple exercises that, again, the North American Spine Society recommends for dealing with low back pain and as well as maintaining good core strengths. So walking, as we already talked about, standing extension, simply just leaning back and doing that, just holding that for 1 or 2 seconds. Going down on the ground, you can use a mat or a carpet. This bottom left image is showing a stretch where someone lays on their torso and uses their elbows to bend up. And then having good standing posture, as shown on the right in figure 5. This young female patient, instead of standing bent forward, we want you to stand up tall. And then seated posture like we talked about earlier. These are just very simple exercises and things that one can do. Okay, so what are some other cases where back pain might be surgical, where you might want to see a specialist to think about it? Nerve or spinal cord compression, trauma, tumors, spinal deformity. Now, you in general are not going to know necessarily if one of those things are your problem unless you've already been diagnosed, but they'll manifest in certain ways, and I'll tell you about that with a couple of specific examples. So here's a patient who came to me with cervical stenosis. Very common also with aging is some degeneration of the discs, and that could be in the neck, in the mid-back, in the low back. This was an example of a patient who had some degeneration of the discs in the neck, and what you see highlighted in that circle was that the couple of discs that were degenerated were pushing back on the spinal cord, and for this particular patient that was causing neck and arm pain. The hands were not working the same, they were dropping objects. They're also having some numbness, and when I examined them, I noticed some problems with their reflexes. So this can be treated in a variety of ways. I happen to treat this particular patient with a disc replacement, which is a smaller surgery where a patient maintains their range of motion and doesn't have to be fused, and this particular patient was able to recover well from this and leave the hospital very early. As I mentioned, very common condition is degenerative disc disease. We would see this in most people 70 and above if we got an MRI, including some people, many people would be asymptomatic. So what's critical for a provider like me is putting that together with the patient and making sure if they have this, that it fits and we think that is a cause of their symptoms. Now, there are some emerging minimally invasive therapies for changes like this. We will always start conservative first, but if conservative therapy fails, there are things like nerve ablations that can be done in an outpatient setting and often can work for pain that we think is coming from the vertebrae, what we call vertebrogenic back pain. And conservative therapies are things like this: anti-inflammatory medications, neuropathic medications, physical therapy. We try to avoid opioids and muscle relaxers, which can have a lot of side effects, particularly in senior patients. So again, these are some of the things that can cause back pain to be surgical. In particular, this is what the patients themselves should think of. What are red flag signs in which you should see your doctor and potentially be referred to a specialist like me? If the pain is worsening, in other words, if it doesn't get better with time or with trying simple things, if it's associated with shooting pain down an arm or leg, if the limbs are weak, if there's difficulties with balance or walking, and if there's difficulty controlling the bowel or bladder, all those are red flag signs where you should see a medical provider to see if you might need a surgical therapy. So one last thing I'll leave you with is, what does the future look like? There will be genetic tests that allow us to tell how aged someone's body is beyond their chronological age. We all know that some people who are 70 years old may be super active, maybe skiing every weekend, may be involved in sports and able to do a lot of activities. And others, the same age, might be quite debilitated and have very sedentary lifestyle and suffer from chronic pain. Why are they so different, and why might they do differently in surgery? So some of my colleagues at UCSF did this interesting study where they looked at a genetic marker, the telomere length, and for people who had the same age but had this different genetic marker, they had different complication rates during surgery. And this may be something that we can use in the future to help predict who's likely to have a complication and to separate chronological age from biological age and how people really are appearing and performing other than just the number of how many years they've been around. So I'll stop with that and tell you that my Washington practice is quite diverse. I am happy to offer patients no surgery if they don't need it and try to help them with non-surgical measures. And then if they do need something surgical, I do cases from the smallest to the biggest and try to do minimally invasive techniques whenever possible. So thank you for listening, and I'm happy to take any questions.
Thank you, Dr. Saigal. By the way, Dr. Saigal's information is here, and you could also find him on the Washington Township website. We do have a couple of questions from the Facebook audience. The first question is, if surgery is needed, what can I expect for recovery time?
So that really depends on the surgery, and it varies widely. So there will be, for example, minimally invasive, motion-preserving surgeries like the cervical disc replacement that I mentioned. A case like that, the patient may go home the same day or one day after surgery, and their recovery is going to be very fast. I like for patients like that to get up and around the same day of surgery. There's no limitations for bending and twisting, so they can get back to their daily routines almost instantly. Then there's other cases that, such as spinal fusions, that are going to have some more restrictions. And we still try to do those minimally invasive to increase the speed with which people can resume their activities of daily living. But for that type of case, patient's going to be in the hospital for at least a few days and often several weeks of limitations with bending, twisting, and lifting. So it really depends on the condition and the treatment.
Okay, thank you. And then our next question is, do you have any suggestions to help with back pain during sleep?
I have some small suggestions for that. That also really depends on what the problem is and what a patient is dealing with. There's not one specific bed type that I would recommend. That's a question I would often get in clinic. But I would tell patients to try to have the best ergonomics they can when they're sleeping. Some people, by their nature, prefer to sleep on their belly or on their back or on their side. For side sleepers, it's important to just have pillows so that your neck and spine are all neutral and you're not bent to one side or the other. And similarly, if you're a belly or a back sleeper, just try to have the best ergonomics you can. Some people get comfort putting some pillows under their knees to unload the spine a little bit, but it really depends on the specific person and what their specific issue is that's causing them pain.
Perfect, thank you. And then our last question is, I've heard that Washington Wellness Center offers Tai Chi and yoga classes. Would you suggest I take these classes to help with my spine health?
Absolutely. I'm a big proponent, again, of those softer type of exercises. I think Tai Chi is great for both balance and doing some movement, and similarly for yoga. We've seen a lot of benefit from those exercises, and I'd encourage everyone who has any interest in that to consider doing those, especially in the senior years.
Thank you. That concludes our Facebook questions. I could take questions from the audience, and I will bring you the microphone if you have a question. You can raise your hand. Okay.
Thank you. Hi, Doctor. I wanted to know if when you're driving a car, is it a good idea to lean into the headrest, lean back into the headrest for support, or to sit up straight?
So it is a good idea to recline just a little bit, but to maintain, again, good posture where you're looking straight without your neck straining too much. Basically, simple advice is try not to have your neck or your low back strain too much when you're driving. And for you, that's going to depend on your car and what's the position for comfort. So I wouldn't say that you have to force yourself to lean back into the headrest, but rather find a position that feels neutral and comfortable where your neck is not doing any extra work. If you comfortably sit back with a little bit of pressure, go for that. If sitting upright with no pressure feels natural for you on the head, that's fine too. We just don't want your neck to be cocked forward or backwards and for the neck muscles to do any extra work.
One more thing. When you take in calcium, the body doesn't choose where the calcium goes, right? It just sort of goes wherever. Because I know I have calcium in places in my body where it shouldn't be, or it's not a good idea for it to be there. So if you're trying to strengthen your bones, how do you know what the right thing is to do, so that you don't end up with this extra calcium in odd places?
Yeah, great question. I'm glad you brought that up. And you'll notice one thing on my slide that I didn't mention was a calcium replacement, because I think a lot of people don't need that. And before doing a calcium supplement, I would definitely have you talk to your provider. If you have normal calcium levels, you very well may not need that. And in northern climates, many of us have some degree of vitamin D deficiency, and it's worth getting that checked if you have any suspicion of that, and doing simple things like I said, like getting some sunlight exposure. But actually supplementing with calcium or vitamin D, generally you want to talk to your provider because you don't want to have too much. You can, certainly either way can be problematic if you have too much supplementation. And if you're going to start on your own with anything over the counter, I would not recommend going over something that says 100% on the back of the label. You don't want things that are 1,000% or like really too much. So be conservative and safe, and then any calcium or higher supplementation, talk to a provider.
Thank you.
Thank you. Are there any other questions? Okay. Well, this does conclude our program. And we'd like to thank you, Dr. Saigal, for this insightful presentation and for taking your time here today. And thank you, viewers, for tuning in. The entire broadcast of today's presentation is available on our Facebook page and YouTube.